critical limb ischemia, which may be associated with rest pain, along with tissue loss in the form of non-healing ulcer or gangrene. And the compensation by the body is made in the form of neovascularization, which includes vasculogenesis, angiogenesis, and arteriogenesis. Coming to vasculogenesis, it is a de novo formation of embryonic blood vessels from the progenitor cells called hemangioblasts, which may further transform themselves to hematopoietic precursors and endothelial cells. And these hematopoietic precursors and endothelial cells will differentiate further to endothelial cells and smooth muscle cells and pericytes. And the pericytes will help in decreasing the capillary permeability and increasing strength of the blood vessel. And the post-embryonic adaptive vasculogenesis may be in the form of arteriogenesis and angiogenesis. This is a diagrammatic representation of vasculogenesis, which may progress either to arteriogenesis or angiogenesis, which will start from capillary sprouting. Coming to arteriogenesis, it is in view of progressive arterial atherosclerotic disease, in view of stenosis or occlusion, the body will compensate in the form of formation of collateral vessels with remodeling from the pre-existing arterial and arteriolar connections. This arteriogenesis is induced by the changes in the hemodynamic forces, that is the fluid shear stress. Due to the circumferential increasing in the thickness of the wall due to progressive atherosclerosis, there is changes in the fluid shear stress. The fluid shear stress is directly proportional to the flow velocity and is indirectly proportional to cube of the radius. So even with 1 mm of change in the radius, the fluid stress, shear stress will increase, which may stimulate arteriogenesis. The fluid shear stress, which initially causes activation of endothelial cells, which leads to release of nitric oxide from the endothelial cells and is catalyzed by endothelial nitric oxide synthase. Along with the release of nitric oxide, the endothelial cells also activate macrophages and smooth muscle cells. And the nitric oxide leads to smooth muscle cell relaxation and vasodilatation beyond the obstruction. Nitric oxide activates the vascular endothelial growth factor secretion from the endothelial cells, which result in endothelial cell adhesion molecular release. Along with monocyte chemotactic protein 1 and endothelial cell adhesion molecules, both of them results in the production of a sticky endothelium, which will cause a leukocyte to get attracted, adhered, and invasion of the capillaries and collateral blood vessels. And the activated monocytes will release a large number of tumor necrotic factor alpha, which leads to monocyte attraction. The platelets will get adhered and activated and leads to release of large number of growth factors, interleukin 4, which further leads to monocyte adhesion. And these monocytes will release a large number of cytokines, chemokines, growth factors, and other immune cells, which will help in collateral development. The macrophages releases the proteases, which help in the dissolution of or digestion of the basement membrane and help in remodeling of the collateral blood supply. The endothelial cell proliferation and permeability increases due to the release of these proteases. Tobacco use hampers the collateral development in the form of impairment in endothelial proliferative cell number, function, and migration and adherence. The monocyte at migration is also affected by continued smoking, which is due to disordered response to vascular endothelial growth factor. Further, tobacco abuse causes decreased vascular endothelial growth factor and hypoxic ischemic factor 1, which impairs the endothelial progenitor cell function, which is negatively affecting the collateral development. This is a diagrammatic representation of the immune cells and other cells which are involved in arteriogenesis with ischemia and changes due to progressive arterial occlusion or stenosis. There is changes in the fluid shear stress, which leads to attraction of many number of monocytes like CD8, which further activates CD4. Along with CD4 natural killer cells, these all will initiate inflammatory reactions, and these further and further monocytes are recruited, initiating vessel growth by synthesis of angiogenic and arteriogenic cytokines and chemokines and other growth factors. These are the changes of shear stress, wherein all the chemical mediators are being represented. Coming to angiogenesis, angiogenesis is formation of new capillary formation, and the stimulus for the angiogenesis is the distal ischemia, which the angiogenesis can occur in two forms. One is a sprouting angiogenesis and the other one is non-sprouting angiogenesis, that is intussusceptive microvascular growth. So coming to the sprouting angiogenesis, the endothelial cells which are present will produce projections into the surrounding connective tissue, and further by the releases of macrophages releasing proteases, which leads to breakdown of basement membrane and interendothelial junction formation. Migration of endothelial cells occurs along the projections front, and for these sprouting, the endothelial cells need to be specialized to some particular cells, which are divided into tip cells, stalk cells, and phalanx cells. Tip cells are polarized migratory cells, and which are from the present at the forefront of the endothelial sprout, and which are having capability of branching at the tip of the stalk. They will produce philopedia, which will project projections into the surrounding tissue in response to the stimulus, and they are having a minimal proliferation capacity. This is the diagrammatic representation of sprouting angiogenesis. During sprouting angiogenesis, pro-angiogenic factors like vascular endothelial factors and other anti-angiogenic factors like notch signaling factors regulate the phenotypic specialization of the cells, which are differentiated into tip cells, stalk cells, and phalanx cells, as I have told earlier. The tip cells are responsible for migration of the developing vessel and formation of philopedia. Stalk cells are principally helping in supporting of the developing blood vessel and formation of lumen for the future blood vessel formation. Coming to the stalk, it is highly proliferative area of the developing endothelial cell, which is mainly involved in lengthening of the stalk, and it helps in secretion of basement membrane along the stalk, which in future will develop into vascular lumina for the mature blood vessel formation. And it helps in and the stability of stalk is provided by the adventitial pericytes. The phalanx cells are present at the base of the projecting endothelium, which will become quiescent after completion of vascular branching, and it helps in deposition of basement membrane, and it has tight junctions which are formed via vascular endothelial C adherent molecules. The main function of phalanx is delivery of oxygen and nutrient to the forefront part. Coming to regulation of angiogenesis, which is the angiogenesis is initially initiated by ischemia, distal ischemia. Due to the distal ischemia, there is increased expression of vascular endothelial growth factor. This vascular endothelial growth factor is a potent angiogenic factor which helps in endothelial cell proliferation, migration, and adhesion. The endothelial cells will get bound to vascular endothelial growth factor receptor 2, and which will help in endothelial chemotaxis. The vascular endothelial growth factor is present at the extension of the tip cells, which helps in proliferation of stalk cells and deposition of basement membrane and pericyte attraction and for the capillary network. The vascular endothelial growth factor is helping in inducing the sprouting. At the same time, notch signaling system is a negative feedback system which helps in limiting the tip migration. Notch signaling is by increased expression of vascular endothelial growth factor receptor 1, which competitively binds with vascular endothelial growth factor, limiting the availability of vascular endothelial growth factor for vascular endothelial growth factor receptor 2, which is negatively affecting the sprouting. So that indicates the balance between vascular endothelial growth factor and notch signaling is required for the regulation of sprouting. The transformation to tip cell induced by vascular endothelial growth factor. Delta-like ligand 4 is a notch binding ligand which will bind to the notch signaling cells, which is highly expressed at the tip cells. Increased sensitivity to vascular endothelial growth factor and binding to vascular endothelial growth factor receptor 2. Increased vascular endothelial growth factor and vascular endothelial growth factor receptor 2 binding upregulates the delta-like ligand 4, which further leads to downregulation of vascular endothelial growth factor receptor 2 on adjacent cells. This will help in competitively maintaining the tip position. The adjacent cells of the tip cells will further, in future, will develop into stalk cells and express notch signaling system. The tip cells are having low notch signaling, whereas stalk cells are having high notch signaling. High expression of JAK protein 1 is seen at the stalk cells, which helps in counteracting the notch delta-like ligand 4 activity, limiting the tip migration. Coming to the lumen formation of the blood vessel, it is by tubulogenesis or lumen formation, which helps in transformation of stalk cells to future blood vessels. The endothelial cells will project in as a capillary projections into the in between the capillary networks as a tissue growth. The endothelial cells first initially will differentiate into apical and basal polarity, which is induced by vascular endothelial C adherent molecule. Mechanism of lumen formation is by after formation of these apical basal polarity, the further lumen formation is by three mechanisms. One is by intracellular pinocytic vesicle formation, which will fuse further into vacuoles and further fuse and from the adjacent endothelial cells and result in the formation of blood vessel, lumen of the blood vessels. The other mechanism is a formation of intracellular pinocytic vesicles, which will undergo exocytosis of these vesicles or vacuoles and result in the formation of blood vessel lumen. The other mechanism is reorganization of intracellular junctions through vascular endothelial C adherent molecules, wherein CD34 cells and VC adherent localized CD34 sialomucins are formed to the apical cells, which are negatively charged. And these cells, which are negatively charged, will undergo repulsion and result in lumen slit formation and further formation of lumen. The CD34 sialomucins are rearranged in the later stages to the lateral surfaces of the cells. The F-actin attracted to exposed lumen and vascular endothelial growth factor attracts non-muscle myosin 2 to cell surface and the actomyosin complex along apical endothelial surface. The cellular morphologic changes are led by further luminal expression. Beyond the tubulogenesis, the further lumen expression is by the fluid shear stress. This is the pictorial mechanism of these three mechanisms, like intracellular vacuole formation, vesicle formation, and further fusion and resulting in the formation of lumen. The other is intercellular vacuole exocytosis and resulting in the lumen. Third mechanism of CD34 sialomucin formation and repulsion of the negatively charged particles and resulting in the formation of lumen. The other mechanism is intussusceptive angiogenesis, wherein non-sprouting, this is called non-sprouting angiogenesis, which leads to transcapillary tissue pillar development, and which these transcapillary tissue pillars fuse in future life and result in new blood vessel formation. Initially, cells are in contact contact will occur between the opposing cells, and this further the endothelial cells will come and oppose with each other and result in the formation of bilayer formation. And later there is reorganization of endothelial junctions, which further leads to development of a pillar core. The pericytes, myofibrils, and interstitial cells are attracted, which will cause perforation of the endothelial bilayer and further leading to development of new blood vessels. And the collagen fibrils are deposited, which are the backbone for the new coming blood vessels. This is the mechanism of intussusceptive growth, impingement of the endothelial cells along with the lumen into the lumen, leading to creation of a bilayer, and this bilayer then develops perforation due to impingement of pericytes, myofibrils, and interstitial cells, and further development of new blood vessels. After initial capillary formation, vasculogenesis or sprouting occurs. Intussusception is initiated, and the benefits of intussusception leads to rapid capillary expansion and remodeling. And this is by intussusceptive microvascular growth, arborization, that is vertical pillar formation, which further leads to arteriole and venule development, and intussusceptive branching remodeling. The pillars from the endothelial cells are reorganized and merging of tissue septa will occur, and in future horizontal folds are developed, which leads to development of new blood vessels. The pillars will get detached from the remaining connections and a new blood vessel is formed, separating the feeding vessel from the capillary flux. The hemodynamic forces like fluid shear stress further helps in arterial tree development. This is how the intussusceptive angiogenesis occurs. Intussusceptive, the primitive capillary plexus undergoes organization and development into mature blood vessels via intussusceptive angiogenesis, which is divided into intussusceptive microvascular growth, intussusceptive arborization, that is branching, and pruning into the branching. This intussusceptive branch remodeling, that is a final process that alters the vascular network. Adaptation of angulation at branch points helps in developing branch remodeling. This is not involved basically in new capillary formation, but it helps in branch remodeling. Vascular pruning also occurs with intussusceptive branch remodeling. Luminal obstruction leads to regression of blood vessel in response to oxygen tension and growth factor. So the benefits of intussusceptive growth are minimal endothelial proliferation, capillary expansion, and mainly by rearrangement and remodeling, and have low capillary permeability and minimal tissue disruption, which leads to less porous capillaries. Remodeling and pruning. Remodeling of capillary network is in response to nutrient requirement, growth of blood vessels receiving flow and regression of the others. The vessel alterations are due to increase in luminal diameter and maturation. Pruning is a dynamic process of vessel which leads to vessel regression in response to decreased blood flow and possibly a reduction in vascular endothelial growth factor. Areas of low shear stress leads to pruning, allowing blood flow into the well-perfused blood vessels. After proliferation, remodeling and leads to vessel maturation, which further leading to signaling of the endothelial cells, pericytes, and smooth muscle cells and extracellular matrix. The role of microRNAs in neovascularization. MicroRNAs are endogenous non-coding RNAs which help in regulation of many genetic inhibitory factors. They will bind to 3' end of the untranslated reception of the target messenger RNA. The 3' UTR specific sections of mRNA follows the stop codon of coding region, which are helping in which are the regulatory regions. They influence the post-transcriptional regulatory regions. A single microRNA can downregulate multiple targeted genes. Multifactorial physiologic processes are influenced by a single microRNA. The microRNAs are involved in angiogenesis by various interactions between transcription factors or cytokines or cell adhesion molecules. And it is involved in adaptive and maladaptive process. Adaptive process like collateral development and capillary formation, maladaptive process like aneurysmal formation. Vascular cell adhesion molecule 1 is inhibited by microRNA mRNA 126, which reduces the leukocyte adhesion to endothelial cells, which is leading to inhibition of angiogenesis. MicroRNA 126 promotes angiogenesis by inhibiting SPRAD1 receptor and PIK3R2 receptor. MicroRNA 155 is causes activation of T cell and B cells and monocytes and macrophages, which are helping in anti-angiogenic and pro-arteriogenic. There are various trials for the peripheral genetic therapy, protein therapy, and cell-based therapy in view of non-reconstructible disease or advanced peripheral arterial disease for the stimulation of neovascularization. Among gene therapy, protein therapy, and cell-based therapy, gene therapy and protein therapy are having limited results, whereas cell-based therapy is proved to have good results. Coming to gene therapy and protein-based therapy, vascular endothelial growth factor, intramuscular or intravascular injection is used in gene therapy. The vascular endothelial growth factor promotes endothelial proliferation, migration, and lumen formation, and helps in monocyte chemotaxis, which further relays large number of growth factors, chemokines, cytokines, and immune cells, which are helpful for arteriogenesis, which helps in increased collateral development. There is an objective evidence of improvement in ankle brachial index by gene therapy and healing of ischemic wounds and limb salvage. And predominant side effect of vascular endothelial growth factor being edema of the affected limb. Coming to fibroblast growth factor, which again helps in proliferation, migration, differentiation, and potentiates the effect of vascular endothelial growth factor. Traffic trial is a trial which uses fibroblast growth factor, intramuscular and intra-arterial injection, which showed an improvement in exercise tolerance at 90 days. And there is no objective proof after 180 days. And a Talisman trial is another trial of using fibroblast growth factor, which demonstrated twofold risk reduction for all amputations using fibroblast growth factor. Coming to hepatocyte growth factor, which helps in angiogenesis, stimulation of angiogenesis. It enhances the endothelial function and activation of delta-like ligand 4, which is a not signaling binding protein, which helps in proliferation and migration. there is an increase in TCPO2 and no improvement, but as such, there is no improvement in ankle brachial pressure index or wound healing or amputation rates. Developmentally regulated endothelial locus, which is an angiomatrix protein, helps in angiogenic response. Angiogenic initiating response through alpha V beta 3 dependent. It helps in endothelial cell attachment, migration, upregulation of angiogenic phenotype. The Delta trial is a one which uses the developmentally regulated endothelial locus, which help there is an improvement in exercise tolerance of the patient after using Delta regulated endothelial locus, and there is delayed onset of claudication and improvement in quality of life and ankle brachial pressure index. The other gene or protein therapy is using hypoxia-inducible factor 1, which regulates neovascularization in response to ischemia. The hypoxia-inducible factor 1 stimulates the release of vascular endothelial growth factor, which further causes release of endothelial nitric oxide, helping in vasodilatation and stimulating angiogenesis in ischemic tissue. Coming to cell-based therapies, endothelial progenitor cells like from bone marrow or peripheral blood cells are used. This helps in postnatal vasculogenesis. The recombinant granulocyte monocyte colony stimulating factor are used intramuscularly or intraarterially. And STAR trial is a trial which demonstrated the benefit of granulocyte monocyte colony stimulating factor in inducing the neovascularization. CD34 endothelial progenitor cells are used, which help in improvement in and pain-free walking distance, TCPO2 and toe brachial index. The bone marrow derived cells are again another cell, type of cell-based therapy. The bone marrow cells are extracted from, or the endothelial progenitor cells are hemangioblasts extracted from the bone marrow, which are used for intramuscular, intravascular, intraarterial injection, which will further differentiate into endothelial cells and helps in angiogenesis. These bone marrow cell mononuclear cells are pro-angiogenic, helping in improvement in rest pain, ulcer healing, and limb salvage. The intramuscular or intraarterial injection may be extracted from bone marrow or peripheral blood cells. Pause.
Dattatreya, very nice presentation actually. It's a difficult topic to start the session, I think. So, can you hear me?
Yes, sir. Yes, sir.
Yeah. So, basically, what we have to understand that this question usually is for exam purposes also and practical. So, for exam purposes, you have to understand two things, that there are four terms which they ask: vasculogenesis, angiogenesis, and arteriogenesis. So, could you realize the difference between these three?
Yes.
So, what is
Yes,
it like?
sir.
So,
Yes,
just
sir.
for summary, what is the difference between vasculogenesis, angiogenesis, and arteriogenesis?
Sir, vasculogenesis is the de novo formation of embryonic blood vessels during embryonic period from the progenitor cells, which will differentiate into endothelial cells or smooth muscle cells or pericytes. Arteriogenesis is development of new collateral from the pre-existing capillary arterial and arteriolar connections in view of stimulus from the fluid shear stress due to changes in the hemodynamic forces due to progressive arterial stenosis or occlusion. Angiogenesis is formation of new capillary meshwork in response to distal ischemia in order to increase oxygen and nutrient supply to the distal tissue.
So this is very correctly. So we have to understand these three things. And then in angiogenesis also, if it comes, there are two forms. So one is sprouting angiogenesis and one is intussusceptive angiogenesis.
Yes,
so usually when there is hypoxia, we see sprouting angiogenesis. Intussusceptive is more seen in the embryonic forms where rapid formation of capillaries has to occur.